sir. As each presenter comes forth, feel free to take notes and pin your takeaways for future and further discussion. Community trust and distrust has been at the forefront of many discussions and the frustration of some since COVID-19 wreaked havoc across our lives. Well, building community trust during the coronavirus is the topic of our next presenter. Dr. Patricia Harris is a board-certified psychiatrist from Atlanta, has diverse experience as a private practicing physician, county public health officer, patient advocate, and medical society lobbyist. Dr. Harris was the 174th president of the American Medical Association and the first African-American woman elected to that position. Dr. Harris serves as the medical editor-in-chief for everydayhealth.com and is also a visiting professor of psychiatry at Columbia University Vagelos College of Physicians and Surgeons. I present to you Dr. Harris.
Well, good morning, and thank you so much. I am so glad to be here. I thank the Glenn Foundation for elevating ACEs. Yes, in the last 5, perhaps 7 years or so, we are talking more about trauma. We are talking about ACEs. We better understand ACEs, but I can tell you, as someone who did some research into ACEs and trauma, maybe about 25 years ago, I can tell you that we certainly didn't have the understanding and we certainly weren't talking about it. And so, yes, we need to amplify and elevate trauma, but we also need to learn the lessons from experiences in COVID-19. It's a tragic way to elevate and learn some lessons, but throughout my presentation, I will hopefully weave and connect some lessons that we hopefully learned. And at the foundation of a lot of those lessons is trust. So again, I thank you so much, those of you who are sponsors today, the Glenn Foundation, and all of you across the country, and I heard across the globe, who have taken an interest in ACEs. And what I hope at the end of the day, that you, as you take notes and you learn, is that you leave this conference with an action mindset. Right now that we know about it, what are we going to do about it? And so I will just tell a little bit about my story and the lessons learned and opportunities through my last year or so, and then hopefully weave that into some action steps. So I'm going to share my screen. And those of you who have presented before know that this is. So let me know if you see my PowerPoint up.
Yes, we can see it.
It's very, very good. So again, thank you so much for allowing me the opportunity to share a little bit about my thoughts and the lessons learned. But first, and I like to try to, not always successful, start every day with gratitude. And one of the things that I want everyone to know is how much you are thanked, and I won't say loved, but how much you are thanked and supported, because sometimes we don't always take a moment for self-care. And so it's always good to thank folks who are in the fight. Now, here you see a sign from the American Medical Association, and we were thanking physicians, but we also took many opportunities to thank those on the front line. But everyone who worked hard over this past year, continuing to serve clients, continuing to think about policy actions. Some of you may have volunteered either on the front line or in your own sphere of influence. So I think everyone certainly deserves a hearty thank you. But this is also my reminder for everyone to remember to take care of yourselves as you are helping others. Those of us in the helping professions sometimes neglect to do so. So here is a photo of me on the night of my inauguration as president of the American Medical Association in June 2019. And one of the things I said that night is, Yes, not only do I want to amplify and elevate the 3 strategic arcs of the American Medical Association, I also wanted to amplify 3 things. Now, remember, this is June 2019. I wanted to amplify the importance of integrating mental health into overall health, because for many years, I know you probably have seen a separation as if our mental health is separate from the rest of our health. And I don't even like the terms physical health and mental health, because it continues to, I think, promote a dichotomy. Although I understand that until we find a new language or new words to use, we oftentimes fall back on our old language. So that's okay. But that night I said, we must make sure that we are connecting the dots and incorporating and integrating mental health into overall health. Second thing I said I wanted to do was talk about the importance of diversifying physician workforce, but not in the service of a checkbox, right? Not in the service of numbers. Numbers are important. Representation matters. But why does it matter? Why is it important that we diversify our workforce? So yes, as a physician, I think a lot and talk about the physician workforce, but I also know how much I believe in team-led care, particularly in the mental health world. And I've demonstrated this in my practice, where I made sure that every day we did a morning huddle. We talked about the patients that we were going to see today. And the patients saw the psychologist and the nurse before they saw me. And at the end of the day, we met as a team. So team-based care is very important, and it's important that the entire team is diverse. But that night, I said, yes, the physician workforce should look just like our nation in the service of health equity. And the third item I wanted to amplify was the importance of childhood trauma. I am a childhood psychiatrist, and in my practice, and I teased a little bit at the beginning, I work a lot in or with children in the foster care system and with the juvenile justice, or who are in the juvenile justice system. And I began to do some research about how abuse and trauma affects the brain. And this was in the early 90s. And I remember doing a literature review and getting a little worried because we didn't have a lot of hard science. But fast forward to today, we know so much more. We know that trauma and abuse affects the brain, because I think I'm probably preaching to the choir today, but I think it's always important to just step back a moment and level set and remember some of the things that we already know, that absolutely adverse childhood experiences, trauma affect the brain, not just our psychological cells, but the actual morphology of the brain. It determines how our brain cells connect to one another. It determines which part of our brain is active and sometimes overactive. So again, 20 years ago, we didn't know as much as we know now, but now we are clear and there is no question. And what we also know now is that it affects so much more. And I'll have a slide about that a little later on. But of course, those of you that are participating today probably know all about that. And if for the new folks that are just learning and appreciating how trauma impacts health, thank you. Thank you for coming today and learning. And all of us should leave this conference being ambassadors, because as a child psychiatrist, and I know many psychiatrists and pediatricians and social workers and psychologists have seen this, that we sometimes forget that we should, that PTSD, post-traumatic stress disorder, is a significant diagnosis that we need to make sure not only we diagnose and get the diagnosis right, but we make sure that treatment structures and the infrastructure is set to deal with PTSD. Because as of today, there is no pill for PTSD. And so it requires a look. It requires trauma-informed systems, and I know you're going to hear more about that later today. I used to always get a question about attention deficit hyperactivity disorder, ADHD. And I was always asked, is ADHD overdiagnosed or is it underdiagnosed? And I would say, and this is a lesson I think I'll come back to at the end, in some communities, it may be overdiagnosed. In some communities, it may be underdiagnosed. We have to have the data. We have to make sure that we are gathering the data and disaggregating that data by race and gender and ethnicity and zip code so that we know where it may be underdiagnosed. But I always said there was one diagnosis that I was certain that was underdiagnosed, and that was PTSD in our children. And so luckily here today, we're talking about ACEs, we're talking about trauma. And so now we have to develop an action agenda, which requires policy and practice to make sure that we are looking for solutions and not just elevating the issues. So I said those three things that I wanted to amplify and elevate, but never did I dream nor wish upon our country COVID-19. But if you think back, COVID-19 has elevated all of those issues. It has elevated the importance of mental health. It has elevated this pandemic, the importance of a diverse physician workforce, a diverse workforce, trusted messengers, as we talk about vaccines. And I'll say a little bit more about that. And it has certainly elevated the importance of trauma. So we go into this, the next phase, with this knowledge. And again, it's what are we going to do about it? What is our actionable agenda? And I will say that any actions, any actionable agenda must build on the foundation of trust. Here's another coincidence or divine intervention. In November of 2019, of course, now we know from the NIH that COVID was likely circulating in November. But I gave my last live talk before the assembled AMA House of Delegates. And I can bet you can guess what the theme of my talk was: trust. Talked about Beyonce. And I'll share with you a little bit more of the details, but I talked about Beyonce, I talked about Stephen Covey, and I talked about Mr. Rogers. And just a quick note, all of them have in their music, in their work, in their art, in their work, talked about the importance of trust. Now, I happen to be privileged to belong to a profession that is trusted. Nurses are trusted. But when they do the survey every year, health professionals are trusted. But in order to be trusted, you have to be trustworthy. Trust must be earned. And so that has to be the foundation of any work going forward, that we have to make sure that we are acting every day, earning trust. That action is sustained. We cannot go into a community for one specific purpose and then leave and expect that community to maintain trust and connection with us. It requires constant care and feeding. And so again, I think lessons that I will weave into my presentation today, but all of them builds on the foundation of trust. So how have we responded? Well, a way to respond, and many have, unfortunately, it's not been universal. The first thing we want to do, and I will say again, let's use this as a metaphor and analogy for any public health crisis. Actually, any concern, trauma in our communities, mental health, diabetes, hypertension, vaccine hesitancy. The first item of business is to make sure that we are providing up-to-date evidence-based resources, not what we personally think will work, not a particular treatment that is our favorite, but the information and our actions have to be up-to-date and evidence-based. Now, I finished my residency in 1998, and perhaps some of the things that I was doing in 1998 are appropriate for today. But if I have not kept up, then I don't think I will be prepared to do what I need to do to serve the patients of today. So it's important that we are always providing up-to-date evidence-based resources, research, and clear guidance from trustworthy sources. Now, certainly from the AMA's standpoint, we wanted to make sure that people recover from the disruption. So what lesson can all of us learn? All of our lives, most of our lives have been disrupted from COVID, but not equally. Early on, I saw a Facebook post, and I can't remember even if an author was listed, but someone said, "We are all in the same storm, but we are not in the same boat." And I love that, because I think that was true. There were some folks who were in this storm that were on yachts and were able to navigate this storm through privilege, myself included. As a physician, I was able to work from home. I was able to do all of my TV appearances from home. I was able to order groceries online because I had a computer and I had broadband and internet access, right? I was able to shield myself from exposure because I did not have a frontline job. But a lot of lives have been disrupted. And so we need to look at this from that equity space, knowing that not everyone has been impacted the same. And as we help our communities, our patients, again, individually and communities at large, recover from the disruption, we have to make sure that we meet people where they are. And I'll say a little bit more about that later. Certainly, it's about reducing obstacles to get patients what they need. From our example and from the AMA, we worked very hard. We worked, and I'm sure there are those on the phone in the policy world who work with CMS, the Center for Medicare and Medicaid Services, in the federal government, to make sure that telehealth services remained available and that they were reimbursed. I imagine I have some folks with some agencies who absolutely need to make sure that they keep the lights on, right, to do the work. I don't think we should shy away from talking about these issues, because we need funds to make sure that we are meeting the needs of our patients. And so it is about reducing obstacles to care. And we can talk about telehealth some at the end about moving forward. And we can talk about perhaps what should we continue to do in telehealth and telepsychiatry, and what might not be working. And this is the last thing I'll say about that. When we talk about evidence-based, and this last one, science-based equitable policies, let's make sure that we at some point go back and do what I call inspect what we expect. A lot of times a policy is written, a law is passed, a new program, a new practice, and we all are excited about it, good data. But sometimes we forget to, at some regular cadence, go back to see if it is doing what we want it to do, if it is really helping our patients. And by the way, at the end of the day, that is the name of the game. Are our communities better? Are our patients better? Do they have better health outcomes? If the answer to that is no, then we should say that and then course correct. Doesn't mean anybody did anything wrong, but we have to be willing to be on that constant cadence of evaluation and course correcting. This is what science does. Now, I know that at some order, it was confusing to the public, because as we learn more, recommendations that came from public health and physicians and the CDC and all of the agencies necessarily had to change. And I understand that's a bit a difficult sometimes for the public, but that's on us, and that's a communication piece. And I talk a lot about communication, and I think one of the lessons learned, I'm not going to focus on that today, is what do we do going forward regarding communication? Now, you can specifically talk about communication and trust when it comes to vaccines, but I think we have a broader issue here. How can we communicate? And let's talk about ACEs. How can we communicate the need for those of us, we're probably preaching, the choir is here today, but we need to be ambassadors for those who don't understand ACEs and don't understand trauma. And so we need to think about how we communicate that. And the communication strategies may be different for different audiences. Again, just honing down on the importance of keeping science at the forefront. Again, I had the wonderful privilege and the platform of representing the AMA early on, and we focused on science, data, the evidence, and the facts. And in fact, I don't know, sometimes I want to go back and do a study, and this was early on, but there became a groundswell of folks who began to talk about, we have to follow the science. We have to make sure we have the data. We make sure we follow the evidence. So I'm hoping that in some small way, I had a little bit to do with that. But we always have to make sure that we are speaking from what we know works. And that doesn't mean that we cannot think about promising practices, emerging practices, but we must be clear. There must be clarity as to whether something is an evidence-based practice, if it's been proven, or if it's a promising practice, not proven yet, but we have some good data. That's what we all have to wade through, and that's okay, as long as we use the right words. And to me, transparency, we will go a long way. And most people say that a part of transparency is truth telling. I'm sorry, part of trust is truth telling. And so you have to be transparent. Many of us, myself included, talked about the side effects that I had after I received my second dose of the Moderna vaccine. Why? A worst case outcome would have been to pretend that there are absolutely no side effects and you'll be fine, right? No side effects. And then a person says, all right, I trust Dr. Harris. I trust Dr. Glenn. I'm going to get this vaccine. And then the second dose, they have a lot of side effects. They're in bed the next day, which I was. People will say, oh, nobody told me this. They weren't transparent. Oh, I can't believe what they say. So as we think about trust, we have to make sure that we are committed to truth telling. We just need to let everyone know sometimes the good and the bad, what we know and what we don't know. As I can say from my patient experience, my patients were always happy for me to tell them the negative side effects and what might happen, as well as why I thought the medication or the therapy was going to be helpful. So keeping science at the forefront was very helpful. So again, so many lessons, learning moments from COVID-19. We learned, some of us knew. So this is also something that I want to say, because I do get frustrated some when people talk about health inequities, and I'll talk a lot about that today, as if it's a brand new thing. But I imagine everyone on this call was familiar with health inequities. This was not new. It predated COVID. We knew there were health disparities regarding diabetes and hypertension and some forms of cancer. We know that people who are uninsured live sicker and die younger. And we know there's a significant population in the southern states that's African American and uninsured. So I have a slide a little bit about that, just to urge us to not forget about that foundation. One of the lessons that was amplified, I would say, and this I know from being a public health director, is that we did not have a good public health infrastructure in this country. We know that now. Public health is one of those things that you don't see the value every day, the general public. Your water's clean, no one's dying from food poisoning at restaurants, and nurses are getting everyone vaccinated, in public health, and we're making sure that there are women's health services that are available, but clear public health infrastructure. We knew that there was a lack of a mental health infrastructure, and of course, health equities. And there are 10 more that we see uncovered. I will just say a word about, I have one slide on this, I get a little ahead of myself. Police brutality. I just a word about that. Certainly not a new problem. But this country was in shelter in place at the time of Mr. George Floyd's murder. And we did not have our usual distractions. For me, that's going to football games and baseball games and basketball games, and kids weren't in school and people were not. So we were forced to not look away, right? We couldn't look away. And everyone had to see that. But that, again, was not new. But back to this issue about the unequal impact of COVID, certainly amplified during this pandemic. And as many of us already might guess, Black and Brown communities were hit the hardest. Those who did not have the privilege of working from home, those who use public transportation. And so one of the things, and you heard me talk about this earlier, this is part of the action agenda. So if you're writing down action steps, here's one. The first action step was trust and be trustworthy. Here's the second one. In all data, we have to make disaggregating this data a priority by race, ethnicity, gender, zip code. One of the things that was frustrating to me early on, which led to me getting involved in a startup regarding testing was not equitably available. If you had a car, if you had 8 hours to sit in your car and wait for a test, and then you had 3 days to wait for the results, and I don't mean, and that was difficult, right? If you had those resources, but if you did not, you could not get testing. And so in so many ways, we see this unequal impact of COVID. And now we are in the vaccination phase here, and we have to overcome vaccine hesitancy. Now, when I think of vaccine hesitancy, I think of that with a broad brush. And there is not one monolithic group who might be a little reluctant to get vaccine. Now, let me just say, I'm excluding the anti-vaxxers and those who have the data and know the data and just choose to believe in conspiracy theories. But I'm talking about folks who said, I'm just a little bit worried. I need more information. I'm pregnant. I need more information. I do have some issues of trust with the federal government because of the past. Because of what I heard and read about Henrietta Lacks, about the Public Health Service's Tuskegee experiment at Tuskegee. And by the way, just a quick note on that, a little nuance here. I always say the United States Public Health Service syphilis experiment, which is a mouthful, as you can see. It's hard for me to say all those words. I always say all those words because people use shorthand sometimes, and they say the Tuskegee experiment. It wasn't the Tuskegee experiment, it was at Tuskegee, but it was the United States Public Health Service experiment. So words do matter. And we have all this data. And so we have these buckets now. We see some Republican, conservative, white males. I looked at some data the other day who make up the largest class of those who don't want to get the vaccine. And by the way, everyone, this is important. And now we still have some vaccine hesitancy, but at this point, it is about access. Folks have decided, I want the vaccine, but I can't get it. And so now, we have to stay on this. If you look at the data in a broad brush, you'll say, oh, and I bet you, I urge everyone on this call, here's something else. I'm going to give you a long to-do list here. Look at your own county or state. Look who's vaccinated and who's not vaccinated. You must go beneath the top line numbers. You must look at communities, because we still see some numbers of communities of color and others who are not vaccinated. And so now it's time to really look at that disaggregated data. You can look at the 60% and be proud of the 60% statewide. I'm just making up a number here. But you have to then look in your county, because if in your county, it's 95% unvaccinated, you've got a problem. And let me say, I'm not a doom and gloom person, but if the people that are in the hospital right now, who are getting sick with COVID right now, are mostly those who are unvaccinated. And so we have to make sure that we use our foundation of trust to go into the communities, and particularly their communities, our own communities, and make sure that we are doing all that we can. Everyone does have a role. It might not be your job. You might not be a nurse or a doctor or someone who works in healthcare. But even in your agency, broad-wide, you can make sure that there are trusted, reputable resources. Because right now, people go to Google and they go to the internet, or they might even easily get to a conspiracy website and not get accurate information. So I'm going to apologize. Here's something else on your to-do list. Make sure in your own sphere of influence, you make sure that people are getting information. Now, some people may get all the information and then still choose not to get a vaccine. And those are folks that I said, that's fine, because this is your choice, but I'm here if you need me. Please come to me as your trusted source of information, because it's growing, but we're still not there yet. We're still not out of the woods. We do want to continue the progress that we've made. And I was happy to be able to participate with the Ad Council in a campaign, several events targeting communities of color. Actually, I did the flu vaccine too, because we can't forget if this is the other thing now. We're in the summer now, so okay. But remember, I talked about our public health infrastructure. We need to always have a preparedness mindset about public health, about trauma, about mental health. We need to have a preparedness mindset. We need to take this summer, yes, take some time off, self-care, but we need to, as individuals and organizations, get prepared for the next season, right? And again, we'll see what the vaccination numbers show. We need to get prepared for hopefully solidified public health infrastructure, mental health infrastructure, and we need to get prepared for flu. COVID season. Flu is likely going to come back if folks are not wearing masks. And then if you get the sniffles, do I have COVID? Do I have the flu? You heard me say earlier about testing access. So all these things are interconnected, and we need to make sure that we are preparing right now. Again, I think I've already made the point that our health crisis is deeper than COVID-19. And of course, in employment comes, I chaired the AMA's opioid task force for many years. We're not talking about that enough in the Black community. People are dying now less from prescription opioids and some from illicitly manufactured fentanyl, which is opioids that folks are buying illicitly. And the overdose rate is increasing among African Americans. So again, we have to make sure that we have armed ourselves with the facts and we get the data, and then have an action agenda to talk about all of these. Racism, I'll just quickly say here, difficult conversations. I can share that I've personally had some difficult conversations, but as a psychiatrist, I realized that, and I know my good friend and colleague, Dr. Stewart, is on the phone. Many of us in the mental health field are more comfortable than others having uncomfortable conversations, surfacing the whispers, I say, but we have to have this conversation. But we also, as we have these conversations, have to insist, and this is what I do, that we're having a conversation about a shared definition. And so this is the definition that I like to use from the past president of the APHA, Dr. Kamara Jones. And so you can use whatever definition you like. We are going to have to, going forward, have these conversations. And how do you best have conversations about very difficult topics? Trusted relationships. I think if you have these conversations with people that you trust, first and foremost, they are conversations that become a little bit easier to have. I've already made these points about some of the origins of trust. I'll say here a little bit about how I think about health, because some people think about traditional health and then there's everything else. But every organization that you belong to likely can find yourself somewhere on this slide. This is a Bay Area Regional Health Initiative, a framework that they use, and they point out all of the opportunities to create health and all of the actors involved. and it is living conditions. It is individual behaviors, yes. It is institutional inequities, right? It is history of redlining. And I'll just use that example because I use that example a lot. People always say, well, redlining, what does redlining have to do with health? And just the punchline is, in Atlanta, I worked on a project and we did a map overlay and we looked at zip codes of where folks had the lowest life expectancy. These were also the zip codes where there were redlining and housing discrimination. So I know, again, on this call, everyone knows this, but let's take this information out to those who don't appreciate and say, I work in city planning. I don't have anything to do with health. You know, I make laws for X. I don't have anything to do with health. This slide shows that everything and everyone has an opportunity to either create a healthy environment or detract from health. And those determinants are upstream, midstream, and downstream. And all of us can find ourselves and our agencies in these places and make sure that we have an action agenda in these places. This is a slide I like because it makes a couple of points. First of all, I've already talked about we have to have these infrastructures in place. We have to meet people where they are. When I was training, we had a training clinic and we had a 70% no-show rate. And we were talking about that one day and I said, you know, let's look at our clients who come to see us. They often have to rely on public transportation. And so where it takes me just maybe 30 minutes to get to where I need to go in Atlanta because I have a car to get to my doctor, someone may have to take 3 hours on a bus with more than one, maybe, and I'm a child psychiatrist, of course, so we were seeing children. Sometimes they had siblings. If there's no daycare or childcare, those are also barriers. So we have to make sure that we are meeting people where they are. We are integrating care as much as we can. I'm so proud of work we did in Atlanta where we had public health and behavioral health and primary care in the same building, as well as a drop-in daycare, as well as oral health services. And by the way, even I have been neglecting to do this. We don't talk about oral health services enough, and we need to do that and integrate oral health services. But we also had our employment team and our housing team. And by the way, our arts team all together. Again, in that partnership, trying to meet people where they are, providing them services. And this slide shows us that we need to center equity. And equity is not about one size fits all solution, giving people what they need. Giving people one thing or what we think they need. It's about giving people what they need. And I'm sure that you've seen this slide before where the littlest kid needs 2 boxes to look over the fence. So that's what equity is about. And it is all about centering care around the individual and the family. I think I've already made this point, but when we think about trauma, and what we saw this past summer, and as we're thinking about trauma and how we are going to talk about this trauma with our patients, and hopefully many of you already are, asking questions about how the events of the summer impacted their health, that's got to be a part of a system that really is a trauma-informed system. So I'm sure you'll talk about that more as the day goes on. And then we have this broader issue around ACEs that we came into this pandemic knowing about, but a lot of people still don't know. And they may appreciate a connection between your psychological health. But I bet you when you say, did you know that trauma and adverse childhood experiences could impact whether or not your child as an adult experiences chronic disease, diabetes, hypertension, cancer? Did you know that perhaps trauma and some of these issues impact women and maternal and infant mortality? So we have to, again, continue to it. I know you are expert at it and you'll learn more, but we have to then, once we know the information, connect the dots for people, because I think people are beginning to understand the information, but they can't connect the dots. Again, we've seen this have an impact on children. Adults are pretty resilient. let me just say that all of us are pretty resilient. This is why I don't believe in or use terms such as tsunami. But we are going to have to be prepared because there are going to be more folks, in my opinion, may be wrong, happy to be wrong, with PTSD and some other diagnoses that we're already seeing in children. And then we talk about mental health and inequities surround mental health as well. We've seen, in some ways, the numbers are not, they ebb and flow and they're up and down in region by region. But here's the biggest issue. The lack of access to treatment is greater for those in communities of color. So that is the key takeaway here. And so what are we going to do going forward to making sure that there's greater access to treatment? Because we see that children are less likely to visit a psychiatrist or other mental health professional, more likely to leave care early. Could that be because the care is not culturally relevant, culturally sensitive? And unfortunately, and I'm, again, as you know, a child psychiatrist, we've been seeing an increase in suicide and suicide attempts in our young Black males, but certainly increasing in communities of color. We have to get prepared now. Do want to say, again, another foundation, we got trust as a foundation. Here's another foundation. We really have to make sure that everyone has access to affordable, meaningful coverage. I don't know, what the rates are in your state. I said earlier that in the southern states, because they have not, many of them have not expanded Medicaid, but Medicaid expansion has been critical for folks getting mental health treatment. And so we at our foundation have to continue to have an action agenda regarding protecting patients' access to care. I think I've already made the point about not only talking about racism, but action on racism. Those of you who are in the policy and advocacy space, you need to make sure that we are looking at policy through the lens of equity. And even the technology space, we have seen just an explosion of innovation, and people are talking about augmented intelligence and artificial intelligence, and there's an app for that. We also have to look at those good things. Again, as I say, innovation, AR, technology, there's promise and peril, but we've already seen some examples where health inequities are worsened. And so please, another thing on the to-do list is look at, we should be at, we've seen telehealth, but beyond telehealth. So we should embrace that, but make sure that everyone has equitable access to the technology and the innovation, and making sure the innovation is not worsening health equity. This is just a reminder slide that policy matters. I've been most of my life, since I got hooked here in Georgia at the Georgia General Assembly, been an advocate for getting in there with policy. I think what first led me to do the research to learn about what was out there regarding trauma and the effects of trauma on brain development was I was an advocate at the Georgia General Assembly for children who've been maltreated, abused, and neglected children. And I wanted to go to that arena with science and data. In order to help our policymakers make policy, they need to trust us that we are coming to them with the facts and with some data. And so we certainly need to make sure that we are supporting evidence-based primary prevention strategies for ACEs and evidence-based trauma-informed care. We have to, and we will see, certainly folks are not able to get away and not in school. So we need to see what the data, we heard some preliminary data that there was an increase in family and intimate partner violence. And we know that that is certainly one of the things on the list of the adverse childhood experiences. We need to make sure that we are all reporting suspected child abuse. And an issue that we don't talk enough about, but I saw so much working with adolescents, was bullying. And we need to make sure that that bullying is a part of this conversation. I know it seems a little bit disconnected, but as I urge you to think about this, I think bullying needs to be a part of the issue. I do believe that we need to get our kids back to in-person learning, but I have to tell you, several of my patients, they did better because they did not have to worry about bullying. It's hard to be a kid right now. Let's just say that. There's bullying. There's all the stuff on the internet that they are bombarded. They have to do school shooter drills. I'm old, I will admit, I didn't have to do school shooter drills, so there's a lot. And then there's all the peer pressure to be perfect and, to look perfect and you have your perfect life. The one silver lining of this pandemic is, and I think you saw that at the beginning of the pandemic, people were on their Zooms, and I think we still wore our makeup and had our hair done, right, and all that stuff. And I think as we sort of navigated through the pandemic, we cared a little bit less about some of these things that I know people are talking about reordering their priorities, and that's a good thing. That's a silver lining that has come out of that. But certainly, just keep bullying is mine as you think about that. I've always been passionate, again, pre-pandemic, pre-AMA, pre-everything, about integrating mental health care, as you heard at the beginning. And so we need policy. We need to make sure that we are working that folks, agencies, all of you, all of us are adequately reimbursed. We need to look at payment models and make sure that there are payment models that perhaps reimburse a consultation, the collaborative care model, for example. So we need to make sure. So I know I'm running short on time. I think I have about 5 minutes left. So I've already talked about workforce diversity. So how do we get there? And each profession will have to find out their own niche, right? I'm not going to pretend to know about every profession. I know the most about physicians and the work that we've been doing for years. And so I'll share those lessons that we've learned, and hopefully some of these lessons will apply. But certainly we know we don't have a very diverse physician workforce at this time. And so we have to make sure that there are policies developed. And I was just on a call. I have the wonderful opportunity to be a part of the Bipartisan Policy Center's task force on looking at the opioid epidemic. But as a part of that, we talked about the need for integrated care, because right now, today, there are not enough of us, right? No matter where you are in the spectrum, there are not enough of us working on this. And so we have to make sure that what can we do today, right now? And there are some collaborative care models. Those of you out there who might be educators, school is such an important place for children. And we want to make sure that there's some great work about school-based mental health care, school-based health care. I was part of a learning opportunity for typical and troubled, because we want to make sure that everyone is trained, and that if a child, to look for the symptoms of ADHD, to look for the symptoms of PTSD, and know that some of those symptoms won't go away overnight. We need to make sure, we need our payers involved. We need the payers not to have any barriers to our youth and parents or anyone getting the care that they need. Listen, I understand rules and regs, but we have to have some of these conversations. Again, working here in Georgia, the children, of course, were covered by Medicaid, but of course the parents weren't in a state that did not expand Medicaid. So I found myself in a very difficult position. Of course, when you're working with children, you have to work with the parents. But if the parents aren't covered, if they don't have affordable, meaningful health insurance, I could not work with them. Yes, we could do family counseling, but I'm talking about individual work. I know you know about generational trauma. And so it's very frustrating. So I think we need to figure out a way that we can develop these models where we are out of our silos, and we make sure that everyone, again, has that access to care. We need scholarship dollars. The states can do this. If they want more social workers in a particular area, or teachers, maybe they can develop loan repayment programs. And certainly pipeline programs. We have to grow. And we have to start, by the way, I am a very a very huge proponent of socio-emotional development in preschool. So we have to start at preschool. I always say, well, how do you get more physicians? People ask me that. And I say, we start growing them in preschool, making sure they have good socio-emotional development. So this is my last slide. And this slide talks about a framework. So I need to add trust at the bottom here. So trust is the foundation. And we have to center equity. And then we have to have a system that goes from promotion and prevention to treatment and maintenance. It can't be one of these or either or. I always tell when I'm giving talks to young students, I said, if someone comes to you and offers you an either or proposition to run away from that. It has to be all of the above. And we have to have the community conditions that I talked about, the coverage, the engagement of all systems. You see the community, the education system, the judicial system, health systems, we all have to be engaged. And then we have to, again, back to my inspect what you expect, we have to make sure we're all clear about the outcomes, that we define these outcomes ahead of time, and that we are unafraid, we are courageous in looking at those outcomes, and what's working we keep, and what's not working we do something different about. Because if we really are serious, if we are committed, and these are words that I think I want to leave you with, because we have to be intentional, dealing with inequities, dealing with trauma, dealing with ACEs, we have to be purposeful, we have to prepare, and we have to be proactive. So I think I have given you about 100 things on your to-do list today, but rest assured, I share these to-do items with you, and it can be overwhelming. It can be overwhelming. Even those of us with resources, we can get overwhelming. But I don't know about you, but I was inspired on Inauguration Day by our youth poet laureate, Ms. Amanda Gorman. It's a tough time that day, and we have and still see our very democracy threatened. And so again, a little bit overwhelming. But again, when I heard her say this, the last words on this slide, once we ask, how could we possibly prevail over catastrophe? Now we assert, and I'm just adding mine, now we have to assert, how could catastrophe possibly prevail over us? And so I hope you take Ms. Gorman's words with you as you work on the to-do list that I gave you, and I'm sure others will give you today, as we continue to address many of the issues regarding trauma, regarding children, regarding mental health in our country and actually in our world. So thank you.
Wow, thank you so much, Dr. Harris. A wealth of information and instructions. So we know now to be purposeful and proactive. Also that we need to have a mindset and take action. And among other things, that's certainly not even touching the tip of all the information, but we thank you for sharing your wealth of knowledge, your story, and giving us some marching orders in the process. For our participants, as a reminder, you have the opportunity to take notes. There is a virtual workbook in the chat box. Please avail yourself to that. Take notes. I know you have a lot of information just from our first presenter that you can certainly take down. Remember to complete the surveys when they drop and complete them in their entirety. Make sure that you are signed in as the same name that you registered with, because that's extremely important for your CEUs as well.